Hi, good afternoon, Robert. Thank you so much for joining us today. My name is Janet. I'm part of KGI Admissions. I'm part of the outreach team. I'm the Admissions Outreach Coordinator. Thank you for joining our webinar. I just want to introduce our faculty member here with us. This is Dr. Mustafa El-Gabali. He will be discussing advances in diabetes and pharmacology. He's an associate professor in pharmaceutical and applied life sciences here at KGI. I also wanted to give you a chance to introduce yourself as well, since this is a small group webinar.
Hello, my name is Robert. I got my bachelor's in public health sciences from UC Irvine last year, and I'm looking into pharmacy and pharmacy schools, and I'd like to learn more about the field. I have a big interest in pharmacology, so once I do my PharmD, I'm planning on taking out a master's or a PhD in like pharmaceutical sciences or pharmacology or something. I haven't really figured it out yet. So.
Okay, perfect. Thank you so much, Robert, and welcome. And Dr. El-Gabali, I'll turn it over to you.
Thank you. Thanks, Robert. So I'll briefly introduce myself. My name is Dr. El-Gabali. I'm an associate professor in pathophysiology at Pharmacology. I teach the first and second year. My area of specialty is cardiovascular complications of diabetes and stroke patients. So it's really diabetes and neurovascular therapeutics. And pharmacology is essential for pharmacy, medicine, and health sciences because this is the science where we study drugs. So I made this as a brief framework presentation to just give you an idea what kind of topics we typically touch upon when we teach pharmacology. And since I teach both pathophysiology and pharmacology, that will show you actually why we do both. We actually teach patho first so we can see the normal state, the disease states. Then we pick on what we call the therapeutic targets. Then we get into the drugs, how they work, how they produce their side effects, then a quick comparison between this. So this is really a framework rundown of what typically happens in a lecture. And the lecture is more intense, but again, this is not meant to be a lecture, but just to give you an overview of what pharmacology is. I'm also a pharmacist. So when I finished pharmacy, I did my PhD, then a fellowship in clinical trials. So hopefully this will be interesting. So typically we begin with a background about the disease itself. So in this case, we talk about diabetes, and we typically list one of the big guidelines societies that gives us the statistics and epidemiology. In this case is the American Heart Association. And the current estimate for diabetes in US is split between type 1 diabetes, which happens typically in younger patients. And there's definitely an increase about 50% between the year 2000 and 2017 to about 215 patients per 100,000. The US is currently about 350 million now, so you can imagine the prevalence. As for type 2 diabetes, there is also an increase. So we're seeing a concerning trend for both conditions, which again, type 2 typically happens in older population. And the increase is about 95% to an incidence of 67 per 100,000. And this is published in Journal of JAMA. Type 1 is a condition where the patient is typically dependent on insulin, and type 2 is a condition where initially the patient uses oral medications, but eventually, if their diabetes is not controlled, they will use insulin as well. As a general rule, type 2 diabetes, depending on the source you read, is about 80 to 90% of patients. So most of research and funding really goes to type 2 diabetes just because of the large population that has that subtype of the disease, the research interest in this one. And there are factors that contribute to the prevalence of whether type 1 or type 2 that we'll talk about in a moment. So this is a disease condition. What do we mean actually when we say diabetes? What is diabetes? Diabetes is actually classified as an endocrine disease. So it's an abnormality within the secretion of a bioactive molecule, typically hormone, or in this case, a peptide. It's also classified as a vascular disease. That means it affects the vessel and the vascular system, blood, the vessels and the heart. It's a metabolic failure overall. This is the most comprehensive classification. So you will see diabetes in courses like endocrinology. You'll see it in courses like cardiovascular disease, with hypertension, with heart failure, with ischemic heart disease, with stroke, with kidney disease. All these are vascular conditions. And you'll see it in other courses. It's like a staple condition that we typically have a patient case that has some kind of vascular condition, either hypertension, high cholesterol, diabetes. Why do all these classifications explain diabetes? Because if you think of it as an endocrine disease, it's an issue within the pancreas. So if the pancreas has an issue with insulin secretion, so the immune cell will destroy pancreas typically in type 1 diabetes. So that's why the younger population will have it. You can think of it as an endocrine problem because the pancreas is the organ that will secrete the bioactive molecule, in this case insulin, that will travel in the blood stream to do its action in all cell types to control energy utilization or energy use within our body. If you think about it as a vascular condition, because it affects the vascular system, we'll see in a moment how it actually has very bad prognosis or complications or long-term effects if left untreated. But overall, when we look at the cell level, the energy processes, energy consumption and production, kind of like a car. When you put gas in the car, this is the source of energy. So when we eat food as human, this is the source of energy. Insulin is essential to make us use that energy source, which is glucose. If there's an issue with insulin, then the body cannot use glucose and you end up with diabetes. This is really what diabetes is. It's a metabolic failure in energy processes overall, whether using carbohydrates, lipids, or protein. But people typically think of sugar because it's the most famous and hallmark clinical sign that we use to diagnose diabetes. So why do we treat diabetes? So this is a question we ask in any condition, not just in diabetes, because the opposite of this, okay, someone blood sugar is high, above a certain number. So what? Leave it high. Someone blood pressure number is high, above a certain number. So what? Leave it high. The issue is if you leave these numbers high, and in this case, we're talking about type 2 diabetes, since we focus now on type 2, since this is the most common condition. What will happen to your body is complications or poor prognosis. So the issue with short term is not just that your sugar is high in the blood, it cannot get into the cells so they can burn it. Remember, the sugars are gas. Without it, you can't burn it. Without it inside the cells cannot burn it and make what we call ATP, or the coin of energy. ATP is the energy coin that we use to do all this mechanical work and breathe and go around in our life and have all that energy within us. It's not just that. The issue is if you leave blood sugar high enough for so many years, you'll end up with long-term complications, and we split them into what we call microvascular complications and macrovascular complication. Micro means from small vessels, and this is what's shown on the right side of this diagram. And macro means the big vessels in our bodies, the ones that are present in the brain, in the kidney, and in the foot. So this is what's shown on the left side. And this is why we classify diabetes as a vascular condition. It's not just an endocrine condition, it's also a vascular condition. If patients do not treat their blood sugar, or they take medications on and off and they're not what we call compliant, and they don't take them regularly, and they don't take them in the doses that will give us the effect that we want, we will end up in a couple of years down the road, eventually with one of these complications, retinopathy or blindness. So retinopathy, pathy means disease, retina in the eye, and the number one cause of blindness is diabetes, because the high sugar in the blood will damage the small vessels within the retina. There is also a small vessels with circulation around the heart, looks like a crown. And if this is damaged, you'll have heart attacks or angina or ischemic heart disease. So diabetes is definitely a risk factor for heart conditions. And there are also effects on the peripheral nerves. So you'll have things like peripheral neuropathy, sensations that are abnormal, gastric motility, or the movement of the gut is abnormal, and that also goes into erectile dysfunction as well. It affects the nerves and vascular structure there. It's not only these complications within the microvessel structures, so blindness, heart disease, peripheral neuropathy, but also macrovascular disease on the left side. So issues like cerebrovascular disease, typically stroke. So a stroke is when the patient is literally struck by something and falls to the ground. It's an emergency, and diabetes is one of the risk factors that can cause this. Kidney is very sensitive. It has vascular structure in it. If it gets damaged, you have kidney disease. And there's a very well connection between, again, renal disease and diabetes. And diabetic foot infection, if the vascular structure and the peripheral circulation of the nerves, the peripheral neural network is affected, patient will typically not be able to feel injuries, would not feel that pain, which is good as a warning signs. And if this deteriorates, that can cause an infection, and it can be as bad as leading to amputation. So they have to cut the patient foot off. So this is something known as a classic complication of diabetes. So it is not just the issue with energy, but it's the complications of the long term. So from now, you can see a classic theme that we talk about all the time. We don't do this only in diabetes, but we do that in every disease condition we talk about. What is the issue with the disease itself, and how does it connect to the other conditions, or what people think of as complications? We call this prognosis in medicine. So it's multiple issues. And typically when we give our students a case, from this slide, you can understand why we don't just say, this patient is so many years of age, this is the current medications they're taking, and they only have diabetes, how do you treat them? No, we typically throw in a renal condition, a history of heart attack, and maybe problems with foot, because these are all disease conditions that are related to that one common risk factor. And you can apply that stream of thinking to other disease conditions. That shows you the complexity of treating disease conditions, and why when we think of treatment options and drugs, we not only have to think of one condition, but multiple conditions. So we know how diabetes actually can cause complications. So we have to look at a smaller cellular level. How does diabetes damage our bodies? How do all these vascular complications happen? How is it connected to things like ischemic heart disease? So this is when we, in the lecture will be more detailed. Typically, we'll talk about molecular pharmacology and events that happens within target tissues and cells, and how a certain disease condition, in this case diabetes, will affect the structure and the function of a certain location within our body. Because the principle in physiology is structure supports function. The example I typically tell my students is your bone. If your bone is broken, you can't support the mechanical function. You can't walk. You have to wait until it heals so you can walk again. The muscles are injured, you can't carry weight around. So the structure is different. The function of contraction and relaxation is not supported. It's exactly the same in any disease condition. If you end up having vascular structural changes, if you end up having vascular inflammation, immune response, the immune system is triggered by high blood glucose for long times. If we change and remodel, literally change the shape of the vessels and have them become thicker, less elastic, not normal, not responsive, all of these changes will affect the vascular function. So this is just showing the vessel and why diabetes is considered a vascular disease. So we'll go through the process of, say, endothelial dysfunction. What does it mean? Vascular inflammation, what does it mean? Which molecules are responsible for it? Vascular remodeling, what does it mean? But for now, you can just see from the diagram, the shape of the vessel becomes different. It becomes narrower in lumen. You have deposits and changes within the wall, kind of like when you remodel your house. So it becomes more stiff and rigid. So as blood passes through, it doesn't expand and contract as elastic as it should be, which is bad. If it's less flexible, it can be damaged easily. If there's inflammation, that means simply the immune system cells are actively damaging the vessel structure and making it different. That explains actually why things like blindness, because the vascular structure of the retina changes, happen. Why renal failure happen, because the vascular structure of the kidney take place due to these immune cell response. The balance between constriction or narrowing the lumen and dilation or making the lumen bigger, we have these normal responses to accommodate blood flow depending on the need. When you go to the gym and run, you need more blood flow. Your blood vessels will change in diameter. When you're asleep, you don't need that much energy. Your diameter of blood vessels will change because the physiological need is different. This is a physiologic response, constriction and dilation, depending on the need. When you have a disease like diabetes, this normal responsiveness is changed, and that affects blood pressure, heart disease, cerebrovascular health, and kidney disease. So in lectures, we talk more about the molecules and how about the processes of each of these topics and how they connect diabetes to the other conditions. And this diagram is actually showing you how diabetes changes the vascular structure, causes what we call atherosclerosis, hard vessels, which actually is the primary risk factor for ischemic heart disease and angina. This is just one piece of it. So now that we're getting more understanding of the pathophysiology of diabetes, we're trying to understand the normal condition, the physiology, then the disease condition, what changes happen, in this case, the vascular changes, so we can understand how we should treat. So typically when I give slides like this to my students, I'll ask them to think for a moment, talk about among themselves. And before COVID, we had what we call think, pair, share, where two students will get together for like half a minute, exchange their ideas, then 1 more minute as a group of 5 or 6 can share the whole idea, then one student will present, then I'll give a debrief at the end. And the question will be, just looking at that slide and having known about the vascular changes that happen in diabetes, what do you think the targets are that we select to treat diabetes? Would you like to venture to give a guess, or do you want me to just go on?
Well, you would somehow have to try to target the amount of glucose in the blood.
Very good, excellent. So this is the initial stimulus or the cause of injury of the insult. If you target the insult, you theoretically can prevent all these changes down the way. Excellent. This is one of the major modalities we use. Another thing is to try to maintain the balance of everything that became abnormal, restore the balance between constriction and dilation, try to reduce inflammation. We actually give a lot of anti-inflammatory agents, and try to reduce vascular remodeling. So this is great. So if you start thinking this way, students start to build connection between pathophysiology and pharmacology. Literally, the reason why we teach pathophysiology is not just so when you see a case, I identify the signs and symptoms and try to figure out the pieces, but also to think of drugs. Which drug options can I use, drug classes that will help me treat that condition better based on the abnormalities that are present in the patient. In the case of diabetes, so this was an excellent answer. This is perfectly the gold standard of treatment, or most of the drugs actually target that insult. In diabetes, it's also a question of when. So I get asked that a lot. Can we reverse diabetes? And I get asked that question by students in all disease conditions. Can you reverse hypertension? Or in other words, can you cure diabetes? So the word cure, make it completely gone as if it was never there. So I give my students by the end of the course the answer to this, and the answer is, this is just a general rule. Most disease conditions we talk about undergo what we call a lifetime maintenance treatment. But as far as cure, there are few conditions that we can cure. Typically, these are infectious conditions. So if you have an infection, you know the specific cause, which is a microorganism. A good example would be COVID. There's a specific virus, you isolate, kill that virus, you cure the disease. The issue with other disease conditions that are not within the infectious disease realm, we typically, when we talk about pathophysiology, we don't talk about a cause and effect. We talk about risk factors. So this is different from cause. So we don't talk about cure, we talk about maintenance. But the answer is, for all these conditions, diabetes, hypertension, we want to treat the patient early on to make sure these complications are not affecting all these organs and the health of the system that are related and are affected by hyperglycemia. So that's the reason. It's not just to reverse it, it's really to reduce the complications and give the patient a high quality of life. Because think of it this way, if a patient is taking drugs for diabetes and we get them early on and they are well controlled and they are compliant, there is a lower probability of having to suffer from all of these complications. So they mainly have to deal with diabetes and hyperglycemia. But if they come late on or they're not compliant, then we have to treat other conditions, kidney function abnormalities, heart disease abnormalities. Then we get into a completely different set of issues that we cover in pharmacology, which is drug interactions. Theoretically, anytime you get two drugs, there's a potential for them to interact. That interaction can cause them both to be ineffective, which is bad because the patient is not getting treatment, or to make one of them toxic, which is an issue because you have to deal with higher side effects, what we call adverse drug reactions, or nothing, which happens many times. So when we finish pharmacology lectures, after mechanism of action, after side effects, if there are clinically significant drug-drug interactions or DDIs, we'll talk about these because this is something we have to manage as pharmacists. It's a liability if you miss these, because it's something that can be prevented and it's something under the responsibility of the pharmacist to take care of. So this was a brief overview of the framework of the pathophysiology that we typically cover. And again, this was just very bird view highlight framework to show you the topics we touch upon. Then we get into the drug classes that we typically use to treat a disease condition. In this case, we have multiple drug classes. They are bolded. So we have the biguanides, the sulfonylurea, the thiazidinediones, the DDP4 inhibitors. We'll see what that is in a moment. The SLG2 inhibitors, the GLP-1RA. Again, I have a couple of videos for these. And under each class, we have a classic drug or drugs. So typically these drug classes get their names from the chemical structure. And this is where medicinal chemistry and pharmacology come together. Medicinal chemistry shows you the structure of these drugs and how they interact within specific areas within our bodies we call receptors to produce the action. For biguanides, we have Metformin, which is the classic old agents, probably the #1 oral agent people take if they are diagnosed with type 2 diabetes. And this is unusual to have one drug in one class. Typically, you have more than one drug. So sulfonylurea is another old class. Typically, what people could see now is glimepiride. Thiazidinedione, we used to have two. There's actually two, but one of them is restricted access program. The one that is available now is pioglitazone. And the newest agents really are the DPP4 inhibitors, or that dipeptidase 4, which is an enzyme. We'll see in a moment what it does, or what we call Egleptins. They all end in the suffix Gleptin, so we call them Egleptins. So sitagliptin, 6-Egleptin, L-Egleptin, and all that. And by the way, what we list here is generic name. So we ask our students to know the generic and brand, because when you are in a hospital, physicians use this as, I tell my students, knowing the class, brand and generic is like knowing the alphabet. People use it all the time and expect you, when they say something like glucophage, you understand what that is. You know, that is metformin. Or metformin, you understand it's the same as glucophage. Then they talk about how it's used and the doses and the selection and the best option. The other two new classes that we have for diabetes now are the sodium glucose transporter 2 inhibitors. I have a video for this that shows the mechanism of action. And these also end in suffix that's called flozin. They really came up with that from the word flow because it affects something in the kidney. We'll see in a moment. And the GLP-1 receptor agonist. And agonist in pharmacology means if this molecule, which is typically drug, if you talk pharmacology, so we just, let's say drug, interact with the receptor in the body, it will stimulate a process. So we always talk about the key lock theory just to make things easier. If our body is like a big house and that house has so many rooms, which are different systems, and each room has a door to get into a system or a room, each door has a key and a lock. You can't just get into the room. The key has to get into the lock. So the lock is the receptor, which is a specific location within a system or cell. And the key is the drug. When the key interacts with the lock or the receptor interacts with the drug as an agonist, a response happens, stimulation. In this case, if the door opens, in this case, we want to lower blood sugar. So this is where the name of the class came from, GLP-1 receptor agonist. And exenatide is one famous one of them, liraglutide. And again, these are all generic names and there's a brand for each one of these. So this is just the beginning as we get into the classes and we talk about them. And at the end, we actually compare these drugs in terms of efficacy, effect of cardiovascular conditions, effect of body weight, because body weight is huge in diabetes, and major side effect, just like the major theme that runs through each class. If you want to tie all these flozins together, what should you think and remember about them is the urinary tract infection or UTI and genital thrush. And we'll see why, because this is tied to the mechanism of action. So that's another thing we'll talk about in pharmacology, how the mechanism of action that helps the patient can sometimes be extended to be thought of as a side effect or adverse drug reaction. So let's just watch a brief video, it's like 2 minutes, about the mechanism of action of one of these classes, which is the dipeptidyl 4 enzyme inhibitors. So first we'll see what this enzyme does in our body, and when it's inhibited, why is this good in diabetes? So I'll typically show a video, then after the video I'll explain the major points, then I'll leave some kind of a slide for students who are visual. So students who like to watch animation, they can watch the video. If they like figures, they can just see all the information on the slide. And there's a lot of text. So this is again just framework presentation, but a typical slide will have like, I don't know, 12, 14 lines that explains the mechanism of action in details. So let's see how the Egleptins work to treat diabetes. Okay, can you see the YouTube?
Yes, we can see it.
So that's an enzyme, and the class that treats diabetes, targeting that enzyme, inhibit that enzyme. So since diabetes is a vascular condition, let's just think of a blood vessel. It has what we call the endothelium structure, which senses any changes, including high blood sugar. And there's the enzyme that typically the process begins with eating food, the major stimulus to increase blood sugar in our blood. The food is digested, it goes through the intestine, becomes absorbed, and as a trigger, intestine releases what we call GLP-1. The sugar that is absorbed from food will go to the pancreas. And now if you narrow, remember the analogy that I gave, if your whole body is a house and different systems is different rooms. So now think of pancreas as one room. In this case, is an endocrine system that is responsible for insulin secretion. We'll have to go down. So I always tell my students location, location, location. You need to know where the drug works because this is tied to the side effects as well. So if you now zoom in on the pancreas and see the structure of each cell, so this is what you see. This this is the bilipid membrane of the cell membrane. Now this is like door, and each door has what? Lock. A lock is a receptor in biology. So these receptors are what control biological functions. So we'll see different receptors and how this drug works. So let's look at it. You have glucose transporter. It's one type of receptors. You have what we call the ATP sensitive channel. It's responsible for potassium movement outside the beta cells in the pancreas. You have a third type of receptor, voltage dependent calcium channel. That means it operates in response to electricity changes, electric current changes within the cell membrane, and controls calcium movement. The glucose is high in the blood now because we ate. It gets inside the beta cells because you have glucose transporters. It goes through what, if you remember, the Krebs cycle and the glycolysis pathway to produce glucose 6-phosphate for metabolism in general. And ATP is produced. So again, glucose is the gas and ATP is the energy, the heat that's produced in the car from combustion engine. So the pancreas is really the combustion engine in our bodies. We need that energy. The energy will interact with the potassium channel, block it, and now that affects potassium currents. So what happens called depolarization, change in electricity within the body. Let's just say that change in electric currents will trigger the calcium channel to open and push calcium inside beta cells. Calcium inside beta cell is the signal to release stored insulin. Now, insulin in beta cells in the pancreas is kicked outside the cell by a process called excitosis, and it's released in the blood. So now the whole thing is the beta cell act as a scanner or a sensor where it leaks in some glucose when it's high after meals. So it triggers insulin, and now insulin will go and act actually in different body cells. So this is a different lecture. We talk about the effect of insulin on muscle because the major metabolic organ that uses a lot of energy on the liver and on fat cells, because the function of insulin is to make blood sugar go down. It drives the glucose inside the cells so the muscle can use it to produce energy. This is how your pancreas controls insulin secretion. This is the normal healthy response to eating food. High food, high insulin release. Does that make sense?
Yes.
Okay. So where do these agents work? I'll stop here. Let's go back here. So if you go back to the process, step back up, food is ingested, digested, absorbed. There is a trigger to the intestine to release a molecule called GLP-1, going like peptide 1, and that will stimulate insulin release from the beta cells in the pancreas. We'll see in a moment how. There is an enzyme that inactivates GLP-1. Any signal in our body has an on or off switch, just like the remote control. When we need it, when we need GLP-1 after food, it's okay. Okay, we don't eat food now. About 2 hours after meals, you don't need that signal. It should shut down. The enzyme that is responsible for shutting down GLP-1 is DPP-4. So if you block DPP-4, you will keep the GLP-1 signal on. We call this double negative. You put a brake on the brake. Block this, GLP-1 will stay secreted. It will keep stimulating the insulin. And we need this in diabetic patients. We need more insulin from the body to drive the sugar that is high inside the cells. Does that make sense?
Yes.
So this brings up the second part, GLP-1s. We just watched the normal response of body and pancreas to glucose and how it secretes insulin. Where does GLP-1 come from? It comes from the intestine in response to food. So when secreted, it will act on GLP-1 receptor. Every ligand has a receptor. Stimulate the receptor. And there's a molecule inside the cell we call cyclic AMP that will stimulate excitosis, meaning more insulin secretion from the pancreas to the blood. And this is how GLP-1 increase insulin secretion. And this is why when we give drugs that inhibit the enzyme that breaks down GLP-1, so inhibit the breakdown, that means keep it alive or keep it on, GLP-1 will continue to stimulate insulin release. So you can enable the diabetic patient to lower the blood sugar. There's more into, this is the mechanism of action. We spend more details about things like the cyclic AMP, the second signaling molecule inside the cell, the calcium, the channels, and how they interact together. And this is the core of pharmacology signaling pathway. But again, this is just a framework. I tried to summarize everything in one lecture. One slide briefly. So once we talk about the mechanism of action and it makes sense how the drug works, where it works, the students need to be clear on the organ name, the cell name, in this case is beta cell, and the receptor name, and the function of the receptor, and the physiological response. In this case, it's insulin release. If they understand all these details, it makes sense when we talk about side effects. We don't really say side effects in pharmacy. The more professional term is adverse drug reaction, because there is no such a thing as a side effect. All drugs have non-therapeutic effect. There is nothing that is absolutely 100% specific. So we call them adverse drug reaction. So we typically talk about things that are common adverse drug reaction for a class. So things like constipation, because it affects the GI, sore throat, osteoarthritis, inflammation in bone cells. Ost means bone, upper respiratory tract infection. Many drugs have hypersensitivity issues, but the ones we focus on that are specific chemical structures and classes that can give you an issue, but you typically can put hypersensitivity in a class. Liver enzyme, if the drug is metabolized by the liver. Since the drug works in the pancreas, it can actually also cause pancreatitis or inflammation of the pancreas acutely, which can be an issue. So this is a good example of how you think of adverse drug reaction as an extension of the mechanism of action. And low blood sugar. So this is a dose effect, dose response effect. If you give a wrong dose or too much of the drug, then the drug will secrete too much of insulin more than needed. That means much lower blood sugar, which is bad. So we talk about the idea of balance. You need a good range of blood sugar level. Too high is bad, we call this diabetes. Too low is bad, we call this diabetic coma. You don't have energy in your body. It's like a car without gas. Coma is bad because if it's long enough, it will start killing the brain, which is the most sensitive organ, the heart, and the kidneys. Each organ has sensitivity index, if you want to think of it that way, in terms of how long it can stay without sugar. So this is actually an issue in many drug classes that we use to treat hyperglycemia. Wrong dose, or if it's a strong class, you can have low blood sugar or hypoglycemia, high glucosemia in blood, which is a fatal side effect. So something like constipation is a bad side effect. Something like low blood sugar is lethal side effect. So we think of these in terms of severity. And you also get the side effect or adverse drug reaction that are on the news. So a typical one will be FDA drug safety communication. As we use, again, these agents are new. As we use drugs and we know them for at least 5 to 10 years, we get more data about them. The FDA releases warnings. So this is a classic one where they released a warning about DTP4 inhibitors when they were new, and they talk about the data that actually shows how these drugs are associated with severe joint pain. And I list the FDA website for the students, just to show you quickly. I think I closed it by mistake. Never mind. So they can read about the details of that advisory, because when patients read about this, they panic. But the reality is all drugs have side effects. So that brings up a question I ask students. So with all of these side effects, adverse drug reaction, why do we still use drugs? Would you like to guess? Just make a guess. If drugs give us all these problems, why do we still use them?
Because the problems of the disease are way worse than the problems of the drug.
Perfect. We call this risk-benefit analysis. And this is what sometimes students, you have an excellent understanding of the concept for basic and essential concepts from pharmacology. We really are weighing two bad things. Like in cancer, I always use that example because it drives the message. If someone has cancer and they're not treated, the option they have is death. If you give them toxins, which we give in cancers, there's 60% chance they may live. You don't have a third option that says live healthy forever. So we call this risk-benefit analysis. In this case, severe joint pain, stroke, renal failure, blindness, heart disease. Joint pain versus any one of these, joint pain versus all of these that can happen together. So, and I always make sure students understand this because when pharmacists graduate, they're always challenged by the public to make them think what they do is bad in a way. They give things that harm people where this is not the case. And this is why we teach pathophysiology, because you want to see the big picture at the end. What happens if you don't treat? So drugs are not bad. It's just the best thing science has ever given us. And as we improve them, things change. And that's why as new classes come on, you see that's another theme. They can have less severe side effect. I'll talk about that at the end. Or they can have more specific action, or they can be used shorter duration. They will have some benefit that will make them the star for a moment until we know a lot about them. So there's another class of agent. This is very new. They work in a different location. What you're looking at is the kidney, and within the kidney, we actually zoomed in on the functional unit that we call the nephron. And just like any building unit within a tissue, it has, if you zoom in on a cellular level, and in this case, within different segments, where is the pointer? I think I lost. Here we go, laser pointer. Different segment within the nephron, you'll have different cell types and cell receptors. So this is just like a 1-minute video. Let's just watch it quickly. Again, this is the mechanism of action. For another class of agents that we call sodium glucose transporter type 2 inhibitors. Again, the location here is different. The beta cell have different segments. We cover this actually in renal. And if you look at the cell level, there are different transporters. They move molecules in certain direction. In this case, from urine side, from the urine to the blood. Sodium and glucose move back to the body. Sodium here is really sodium chloride, the salt. Your body needs to retain salt and sugar. You need salt for all of these electric processes and nerve conduction and water balance. You need glucose for energy. So if they get secreted as urine is formed, the body takes them back. We call this reabsorption. This is the normal physiology of the kidney, one of the kidney segments in short. And this happens through the sodium glucose transporter type 2. And this is 90% the absorption of glucose. You give the inhibitors that target that channel. Now, glucose will not move from the urine to the blood. Where will it go? It will fall in the urine. So it will be secreted outside the body, and it will be less in the blood. Does that make sense?
Yes.
So this is how you treat hyperglycemia, which is good. It's a need mechanism. You're really targeting the kidney and make sure it takes back less of glucose. It lowers the blood sugar, and the glucose gets wasted in the urine.
Would this lead to the urine looking different?
Definitely. Perfect.
So yeah, you would have to like name that so the patient doesn't like overreact or anything.
Very good. So anytime we have changes in urine color, consistency, frequency, we counsel the patients so they don't freak out and stop taking the medication thinking it's doing something bad. We have to explain that it's actually doing what it should be doing. So in this case, it's doing, if you look at the major side effect, it's really all related to urine and urine tract. So because of that high sugar content in urine, that becomes food for bacteria. So you get higher incidence of urine tract infection. Consistency of urine changes. Frequency of urine increases. Because sugar, if you eat a lot of sweets, you urinate a lot. It's human. This is a normal response from the kidney. And again, another example how the side effects or adverse drug reactions are an extension of the mechanism of action, and things that called ketoacidosis happen, hyperkalemia. I will not get into details of this, but this is all related to that abnormalities and changes that happen due to the action of the kidney. Increased urinations, you have to tell the patient that, especially in diabetes, one of the classic signs of diabetes is increased urination and thirst. So this is actually the effect of the drug because you're losing sugar. So you don't want the patient to think it is related to the disease becoming worse, and so on. Things related to swelling and myocardial infection, again, because of that sugar. And just because the drug lowers blood sugar, there's always the potential of hypoglycemia or low blood sugar levels to lethal levels, and so on. So this gives you an idea. So I'm not going to show the video for the third class, but it's the same. I'll show a video. There's a lot of text. Then there's always a diagram that shows actually the full process from the enzymatic level to the cellular level, to the receptor name, to the signaling molecule. Here is called what's called the G protein coupler receptors and the cyclic EMP, the adenyl cyclase, and how different receptors talk to each other, and how the insulin eventually will interact and give all of these effects that eventually affect the brain, heart, liver, and pancreas. So I typically target it from all of these angles: visual, text, and video. There's a lot of questions to active learning. So the reason I ask you a question or two, it's similar. Well, in the class, we'll have like a mini case, a mini scenario where the students again take a minute or two to read the question, try to figure out the answer. The point is not to know the answer, but it's just to try to think, because I actually want them to make an error in the lecture if they can, because it's corrected. Once it's made, they will never forget it. So when they study, things are clear. Or if they have some kind of idea that is not clear in their mind and they bring it up, I can clarify it more. So these interactive learnings and active learnings are very helpful. So I will typically actually have like a question or two every 4 to 5 slides to do all these active learning and group activity. So that gives you a good rundown of how we talk about pathophysiology, pharmacology, and side effects, and how side effects and adverse drug reactions related. There's a section about drug-drug interaction, which is a completely different section on drugs interacting with each other. Then there's a different section. Okay, we have so many classes, the newer classes. Why did we have to invent DPP-4 inhibitors when we had metformin all the time, and we still use metformin? It's like the most commonly used oral agents. Or in other words, how do these different classes differ? And how to actually compare them to the older classic agents, because they would have not made it to the market if they hadn't had any edge. So the edge I'm talking about here, so this is a good example, is how effective or how efficacious, not effective. Effective in pharmacology means they can produce an effect. All these drugs can lower blood sugar, so they are effective. But in pharmacology, they say efficacious or efficacy. So the difference in the magnitude, how much blood sugar can they lower, is what makes each of these agents different. So this is a comparison between linagliptin, metformin, which is the classic, and linagliptin plus metformin. Metformin higher dose, so the 500 versus the 1000, and linagliptin plus metformin, again higher dose. And what is the kind of drop you expect to see in what we call HA1C? So there is a marker diagnostic test that we use to measure the disease and the patient compliance. Sugar basically interacts with the red blood cells chemically and changes them. And we measure these levels of changed RBCs. We call this HA1C. If you lower sugar, HA1C should drop because the interaction is not happening because sugar is less. So the higher drop you have in HA1C, that means the more efficacious the agent is. So this tells us, okay, Linagliptin is typically comparable to metformin, about minus 0.7% drop in that test. But when you give them together, you have a synergistic effect. You get almost double the effect, which is also equivalent to doubling the dose of metformin. So you can have options. So that gets into the idea, is patient allergic to linagliptin? No, yes, they can just get a high dose of metformin. If patient has problem with metformin, then maybe they can get linagliptin and things like that. So that's one angle we look at when we study these drugs, how different they are in terms of use, compliance, duration of action, allergic reaction, side effects, and efficacy. And that's it. I think I did like a big rundown in how we talk about drugs, how they work, how they produce side effects, how they differ from one another. And again, this is just one aspect. There is more, and how they could interact with one another. So actually what you see here, you can think of linagliptin and metformin together as a drug-drug interaction. It gives you more of an effect. If the doses are so high here and wrong, too much lowering of blood glucose can give you hypoglycemia, which now is a lethal effect. So that's just another example of how you can, through therapeutic error, drug-related error, can cause a problem. So we always think about doses, dose response, efficacy, and things like that. And with that, I hope I give you a good overview of what a typical pharmacology lecture looks like. And by the way, for diabetes in endocrine, they just had it in P1 and they had all of these over a couple of weeks. Just that gives you an idea how condensed this presentation was. Let me stop sharing so I can see the lecture. Okay. Do you have any questions?
Yeah, I have two questions. First question, and I'm curious if this is more so in pharmaceutical sciences or pharmacy. Do you get into the structure of these drugs and the effects that the structure of the chemical would have on its effect?
Definitely. So in a course, let's say this is taught in endocrinology, and it's taught in endocrinology, and it's taught also in, I teach that in cardiovascular 1. You have 3 sections. You have medicinal chemistry, which the faculty is a medicinal chemist that talks about structure-activity relationship, what's called SAR. We actually show you the structure, why these are called gliptins. These names are actually like pieces of different chemical structures fused together. This is not English. And how that structure chemically enables these drugs to interact with these receptors. To me, as a pharmacologist, all I needed to know is the location, the ligand interacts with the receptor, then what happens inside the cells. So I can talk about the mechanism and side effects. Then you have me as the pharmacology, where I talk about what I talked about without structure. Then the third faculty will talk about therapeutics. So this is the clinical piece, where the guidelines, which means how you put all these pieces together. What is the first agent to use in a specific population? What is the second option? Another population. So someone with a liver disease may use one class. Someone with a healthy liver is a different patient population. And it becomes like an algorithm, literally an algorithm. And this is typically the most complex area in the course, the clinical guidelines. Because now you have to think all of the things you talked about, risk benefits, but does it fit the patient? Does it fit the current situation of the patient? And how do you adjust the doses? What are the issues related to the drug? There's a lot of things you have to think about. What is your other question?
And do you do this for individual drugs or just like drug families?
No, so in a lecture, so typically, so for gliptins, literally we will go, I'll talk about that class first. So again, we'll have it in medicinal chemistry, we'll see the different structures. We'll talk about typically target the original drug or the prototype or the parent. then the top 200, like 2 more related drugs. Then in pharmacology, we'll do the same. We'll talk about that class, the drug, the common themes. Then we'll actually have to go through each drug, because some drugs have unique side effects related to them. Some drugs in clinical are present in formulations like once a daily versus injection, or oral versus injection. That is a difference. So in clinical, when this is the case, we talk about the class, then each drug. Now you get into brand and generic, and usage and counseling and storage and compatibility and things like that. So we take it on different levels, but they all come together: the medicinal chemistry, the pathophysiology, the pharmacology, and the clinical. It's really helped from multiple angles, because the purpose is when you get to the end to the case, you'll be able to put all this together to use it in a patient case to manage their therapeutic plan, pharmacological management, drug related. Pharmacy is from pharmacology, right? We always tell our students, you essentially, if you end up working in a hospital or a clinical setting, you become a clinical pharmacologist. So you need to know your clinical sciences and your pharmacology very well.
And I know that you were saying it's not necessarily something that you can cure. In the back of my mind, I was thinking, and this is probably a stupid question, but this is the perfect place to ask it. What if hypothetically we were to give somebody somebody that has diabetes, like a full blood transfusion, and then give them a pancreas transplant? Why would that not work?
Very good. So I didn't talk, there's a piece, the piece that I selected in diabetes pathophysiology was the complications. I didn't talk about how the disease happens. We don't know, there are a lot of risk factors that, I didn't talk about the piece that's called insulin resistance. And someone with type 2 diabetes, the pancreas still secretes insulin, but there are cellular changes that makes the cell not respond to insulin. We still study this. I'll give you my PhD. I studied just one molecule and just found one piece, but I'm just one out of many. We still don't know. You have insulin in your body, but it's not lowering the blood sugar the way it should. So if you replace blood sugar, that is not practical, blood transfusion, sorry, because you have to do this every 4 months. Blood only is good for 120 days, right?
Right.
We do this for patients with certain advanced disease conditions. The other option, and that's not the origin of the disease, the origin is the sensitivity of glucose transporters on the cells. It's not in the blood. The other line of thinking, you're thinking like a researcher scientist. This is great. What if we clone the pancreas to a healthy one? Now you can treat type 1 and type 2, theoretically. If the issue in type 2 is pancreas only, cloning is not that feasible yet. When I talk about liver disease, now we have the drugs that treat hepatitis.
Right.
Recently, we never had these. So there was research on liver transplant and cloning. Maybe in the future, if pancreas cloning happens, that can be a cure for the disease. But we talk about drugs. So what I meant is, can drugs cure the condition? No. Patient will have to take blood pressure medication and blood sugar medication for life to be maintained. That's what I meant from a pharmacological perspective. If genetics and cloning can, which I hope so, can do a lot of these wonders. We can treat a lot of things, cancer, liver disease. Yeah.
I'm more so interested in like pharmacogenomics, and that's not necessarily something that's going to cure it, but like we could maybe, like, depending on your genetic information, try to like prevent the side effects from occurring. We could find out which drug would work best, you know?
There is a genetic component to diabetes, so that's another piece I didn't talk about, the risk factors. Type 1 and type 2, we don't know why the immune system in type 1 destroys the pancreas. But in type 2, there's still risk factor. If there's a family history, there's an increased likelihood. And I've definitely seen that in my family.
Yeah.
And this is common. But still, when we were trying to sequence the genome back in the 80s, and the project was completed, I think, in the 90s, it was a breakthrough because everyone celebrated. We thought everything will be known now. Now we know the human genomic code, but we're still far behind to be able to use it to not just diabetes, for many disease conditions, treat that. So it's a definitely area of research, the genetic origins, the pharmacogenomics, and there is an area of research where we see how people break down drugs differently in the liver, so how we can target them to make the side effects less, things like that. So that is a growing area in pharmacy as well.
Right.
You sound like you're really into the research piece of it.
Yeah, this is all it's just fun. It's fun for me to do. So this is what I do as like a hobby.
Very good.
Yeah.
Well, hopefully that was helpful, and it just give you, the idea was to give you an idea how a pharmacology lecture typically goes. And any other questions?
No, that was it. Yeah. Hopefully I get admitted into the school someday and I'll sit in your lecture.
Good luck. And by the way, yeah, I enjoyed your questions. They're really insightful. That was really nice.
Thanks.
Thank you so much for joining us today, Robert. And thank you so much, Dr. Egleptins, for hosting this for us today. It was really enjoyable to learn more. Robert, if you have any other questions, feel free to email me. I can always connect you to the right PharmD admissions person.
Thank you. Yeah, I'm going to be doing that for the 2023 cycle. So
okay, good luck. Thank you.
And good luck in your application, Robert.
Thank you. Thank you, Professor.
Bye.
All right. Have a great day.
You too. Bye.